Contents will be osteology of mandible, which you already know, inferior alveolar nerve and lingual nerve, which are very important when you're planning your incision and implant placement, drilling. Then relevant implant, the relevance of this anatomy to the implant dentistry, osteology of maxilla, maxillary sinus, very important when you're planning implants in posterior region. Then blood supply, nerve supply, and it's relevant information that you need to know when you're placing implants in the maxilla, because maxilla has in the anterior region your nasal cavity and in the posterior region sinus. So these will limit the height of implant that you can place. So what further modifications you have to do? You have to study that. So this is our mandible. You all have read. So where did you read your mandible from? And we read from this uncle.
The word jaw is used in two ways. When we speak of jaws in the plural, will start, as always, with the bones. The word jaw is used in two ways. When we speak of jaws in the plural, we're referring to both the upper jaw and the lower jaw. When we say jaw in the singular, as in jaw open or jaw bone, we're referring to the mandible. We'll take a good look at the mandible in a minute. Before doing that, let's take a fresh look at the parts of the facial skeleton that we'll be seeing in this section. Here's the psychomatic arch, enclosing the temporal fossa and the infratemporal fossa. Here's the joint surface of the temporomandibular joint with the external auditory hiatus and the styloid process just behind it. In looking at the jaws, we'll start, as always, with the bones. The word jaw is used in two ways. When we speak of jaws in the plural, we're referring to both the upper jaw, the maxilla, and the lower jaw, the mandible. When we say jaw in the singular, as in jaw movement or jaw bone, we're referring to the mandible. We'll take a good look at the mandible in a minute. Before doing that, let's take a fresh look at the parts of the facial skeleton that we'll be seeing in this section. Here's the psychomatic arch, enclosing the temporal fossa and the infratemporal fossa. Here's the joint surface of the temporomandibular joint with the external auditory hiatus and the styloid process just behind it. Here are the pterygoid plates with the pterygoid fossa between them. This sharp projection, just medial to the temporomandibular joint, is the spine of the sphenoid bone. The part of the maxilla that bears the teeth is called the alveolar process. We'll look at the teeth later in this section. The alveolar process ends behind at the tuber. Now we'll bring the mandible into the picture. The mandible develops from two originally separate bones, one on each side, which fuse together here at the symphysis. The mandible is described as consisting of the body and the right and left ramus. The corner between the ramus and the body is the angle of the mandible. The rounded projection that articulates with the temporal bone is the condyle, or condylar process. The narrowing below the condyle is the neck. The sharp, slender projection in front of the condyle is the coronoid process, a major muscle attachment, as we'll see. The dip between the coronoid process and the condyle is the mandibular notch. The angle of the mandible is roughened on the outside and on the inside by the insertions of a matching pair of muscles, the medial pterygoid on the inside and the masseter on the outside, which we'll see shortly. The body of the mandible is described as consisting of the base and the alveolar process. The side of the body slopes upward and inward, slightly on the outer aspect, markedly on the inner aspect. The posterior part of the alveolar process bulges medially above this hollow, the submandibular fossa. This projection in the midline is the mental protuberance. On the inside, this roughened area is the mental spine. Two pairs of muscles are attached here, the geniohyoid and genioglossus muscles. On the inner aspect of the mandible, this thickening below the coronoid process is the buttress. In the middle of the ramus, level with the tops of the teeth, is the mandibular foramen. Just in front of it is a small upward projection, the lingula. The mandibular foramen is the start of a tunnel for the inferior alveolar nerve and blood vessels. A major branch of the nerve emerges on the outside at the mental foramen.
So let's revise it. So this you already know. Then we'll have a quick look at the muscles of mastication.
We'll move on now to look at those four muscles. They're known collectively as the muscles of mastication. The muscles that close the jaw are much more powerful than the ones that open it. Closing is produced by three large muscles on each side, the medial pterygoid, the temporalis, and the masseter. Opening is produced by the lateral pterygoid muscle, which we'll see in a moment, and by some smaller muscles below the mandible that will add to the picture later in this section. Of the four muscles that we'll look at now, we'll start with the one that's hardest to see, the lateral pterygoid. To get a look at it, we need to remove the coronoid process and the zygomatic arch. This lets us see the infratemporal fossa and, behind it, the lateral pterygoid plate. Here's the lateral pterygoid muscle. It's quite small. The lateral pterygoid muscle arises partly from the underside of the greater wing of the sphenoid and partly from the lateral aspect of the lateral pterygoid plate. The fibers of the lateral pterygoid muscle run backward and a little laterally. We'll go round to a medial view to see where they go. The main insertion of the lateral pterygoid is into this hollow on the front of the condylar process. The lateral pterygoid also inserts onto the capsule of the temporomandibular joint. and into the front edge of the articular disc. These windows in the capsule were made artificially, as in the shot that we saw previously. Now that we've seen the lateral pterygoid, we'll add the medial pterygoid muscle to the picture. The medial pterygoid muscle is larger than the lateral pterygoid and runs in a quite different direction. The medial pterygoid muscle arises from both of the pterygoid plates, the medial aspect of the lateral one and the lateral aspect of the medial one, also from this corner of the maxilla, the tuber. The fibers of the medial pterygoid muscle run downwards, backwards, and laterally. They insert here along the inner aspect of the angle of the mandible.
Which are the rest two muscles? You studied about muscles of mastication. One is your lateral pterygoid, the other one is medial. The other two are?
Before adding the next muscle, the temporalis, to the picture, we'll put the coronoid process back in place, since that's where the temporalis inserts. Here's temporalis, the largest of the muscles of mastication. It's shaped like a fan. The temporalis arises from the wide area on the side of the skull that lies within the temporal line. The fibers of temporalis converge from above and from behind on the coronoid process. They insert on the outer aspect and the inner aspect of the coronoid process, and also here on the anterior part of the rings of the mandible. Now to put the zygomatic arch back into the picture. The temporalis muscle lies inside the zygomatic arch. Near its insertion, the temporalis is a thick muscle. It occupies the whole of the infratemporal fossa. The temporalis muscle is covered over by this dense layer of deep temporal fascia. The fascia is attached to bone along the zygomatic arch and all the way around the temporal line. Lastly, we'll add the masseter muscle to the picture. Here's the masseter. It's a thick, powerful muscle. The masseter arises from the anterior 2/3 of the lower border of the zygomatic arch on its outer aspect, and from the whole length of the arch on its inner aspect. The fibers of the masseter muscle that arise on the outside run downwards and backwards. Those on the inside run straight downwards. The masseter inserts into this wide area on the angle and radius of the mandible. The masseter muscle on the outside and the medial pterygoid muscle on the inside converge on the angle of the mandible in very similar ways. Now, let's take a look at the actions of the muscles that we've just seen. The action of closing the jaw is performed by the upward pull of the temporalis, the masseter, and the medial pterygoid muscles. Opening of the jaw is brought about partly by the force of gravity, partly by the forward pull of the lateral pterygoid muscles, and partly by the backward and downward pull of muscles we'll see in a minute that act by way of the hyoid bone. We've not yet seen the two accessory ligaments that restrain forward movement of the mandible. These are the stylomandibular ligament and the sphenomandibular ligament. The stylomandibular ligament goes from the styloid process to the angle of the mandible. The sphenomandibular ligament goes from this small projection, the spine of the sphenoid, to the lingula.
you a clearer picture. So we will get back to the presentation. Okay, so parts of mandible is clear. What we are concerned with is the alveolar part, because the basal bone remains constant. The dynamics change only in the alveolar process. With loss of teeth, you will see, as age advances, you will see there is loss of mineral content also because of age factors. Osteoporosis is a process that starts after 25 years of age, and it definitely hormones are responsible for that. It is more evident in female population. So the alveolar bone is continuously remodeling, and that is the area which shows significant bone loss, and the implant survival is totally dependent on the amount of bone present there. Okay, this we have already covered in the videos. So primary muscles of mastication, as you know, before we have discussed. There are secondary muscles of mastication. When you are opening your jaw, you have some muscles that are attached to your hyoid bone. Okay, so these are called suprahyoid muscles. So these are secondary muscles of mastication: digastric, mylohyoid, geniohyoid, and infrahyoid muscles. We have already gone through this. Now the most important structure in relation to implant placement. So when we look at the cross section of the mandible through this inferior alveolar canal or the mandibular canal, it starts from the mandibular foramen and exits at the mental foramen. So this area between the second premolar to third molar, this is very critical for us. We want to know how far this nerve lies from the buccal cortical plate, from the inferior border, and from the superior border. It is going to vary in different patients depending on size of the mandible, depending on age. Okay, so there's a study where we see that if you look at the lower border, from here the nerve lies approximately 10 to 11 millimeters from the lower border. Nowadays we have advanced diagnostic modalities like CBCT that will give you a clearer picture. So each patient is different, but you have to have an idea. From the buccal cortical plate, it is around 2 to 2.3 to 2.75. So depending on the area, the nerve lateralizes. It is entering into the mandibular canal on the lingual aspect. From the third molar area, it is still in the lingual aspect, and then it starts coming onto the buccal aspect till it exits the mental foramen. So this has to be taken into consideration. For example, you want to place an implant here. So this is the limiting factor, anatomical limiting factor. You cannot encroach this area. So you have to calculate your height of the implant based on this. So superior cortical margin to crest. This is the available height for you. So you have to calculate your implant height based on this. So the CBCT, which you will be going further to investigate such cases, will help you. So from the basal bone, it is almost 8 to 10 millimeters. It is about 1 centimeter before mental foramen. This mental foramen canal turns upwards and forwards, and mental foramen usually lies approximately between the superior border and the inferior border. As age advances, it comes more closer to the crestal portion. So there again the effective height will reduce. You have procedures to bring it down, or you choose another modality, another implant system. Okay. So location of this canal is very important. You have to see that the screw does not encroach this canal. Otherwise the patient will have severe pain which will persist till the implant is removed, and if there is transection during drilling, if you are into the canal, the nerve will get transected and patient may develop permanent paresthesia also. Some partial recovery may be there and sometimes permanent paresthesia may also develop. So you have to be away from the canal. So this is how CBCT will help you to locate where exactly the canal lies. Then you have to predict certain other things. when we have done anatomical studies, we have realized there are accessory canals also present, accessory mandibular foramen present. The location of this accessory foramen is around, horizontally if you come, 10 millimeters, and vertically if you come, it is around 5 millimeters from the lingula. So what is the role? This accessory canal usually runs downwards, comes laterally along with the main canal, and it can fuse here in the third molar area, or sometimes it can continue till the mental foramen. Now you will have a doubt which one is the limiting canal. So you have to choose the one that is appearing superior. From there you have to calculate the height of the implant. Then you have to know that there are bifid canals. There can be various morphological types. It can be unilateral, bilateral, unilateral extending only till the body, only in the ramus or anteriorly. So this you can easily detect on the CBCT. Even in your radiograph, OPG that you take, you can detect. Then you have to know about the mental nerve. Mental nerve, as you see, exits the mental foramen. But when it travels anteriorly, it loops. So foramen is appearing here, but actual extent of the nerve is here. So this you have to take into account when you are planning implant in this area. So you have to keep a distance, safe distance of at least 5 millimeters if you want to place one anterior implant here. This side corresponds to your first premolar usually. Okay, so this loop has to be taken into consideration. From after exiting this mental foramen, it has 3 to 5 twigs. It is not just one cord, one nerve. It has 3 to 5 twigs which will enter the muscles and mucosa of the, which will supply the lip and chin region of that, from the midline of that side. Okay. So in the radiograph you can see the looping like this. So when you want to place the implant, you have to consider this loop. This is the lateral margin of the foramen. This loop, and then safe distance 2 millimeters. So at least 5 millimeters distance you have to maintain for an implant which has to be placed in the interforamina area just adjacent to the mental foramen. So where do you find this nerve? Just beneath the mucosa. If you cut in the vestibule, you will find just beneath the mucosa. So you have, when you are planning the incision at that stage itself, you have to be very careful. Suppose this is a edentulous patient and you want to place multiple implants. In that case, what we do is we perform a crestal incision and expose it. You have to identify the nerve, protect it, and then proceed. So this cross section will help you to know how it loops. It is looping anteriorly also and it is going superiorly also. So again, when you are calculating the safe distance, the height of the implant, you have to take this loop into account. So this is also around 2 to 5 millimeters. So if you are placing an implant here, you have to be 2 millimeters away. If you are in this region, you have to be at least 5 millimeters away from the main canal. I will show you an example like this. Okay. So foramen appears here, but it is looping from here. So from here, if you see, you can have a 5 millimeter distance. Right here, if you see, you have a greater length. From here, if you see, it is 7.5. Here it is around 11. So we are not placing the implant here. We place the implant in the center of the ridge usually. That is the best position possible. So in the center of the ridge, from the superior cortical margin of the mental foramen that you see, from there to the crest you have to calculate the height and be at least 2 millimeters away from this point in the CBCT. If you are taking a radiograph, at least 3 to 5 millimeters away. But preferably these days we don't rely on OPG. Initial days we used to take a IOPA or take an OPG, and based on that we used to plan. But we have realized there are a lot of morphological differences. The OPG gives you just a 2D picture. You cannot visualize it in 3D. So you need a CBCT or a CT. We used to do a dental scan. Now we have CBCT, which is superior. Pointer नहीं काम कर रहा है. So if you take the CBCT section, you want to place an implant in the 5 region, for example, second premolar. Okay? And through the second premolar, you take this section. And you realize the canal is moving upwards like this, and the nerve will exit here in the ventral column. So the height available is not this. The height available is here because we are planning the implant placement in the center of the ridge. So this is the effective height which is available. And CBCT studies have shown 1.7 mm is the safe distance that you should keep, but most of the studies say that at least 2 mm distance you should keep from the canal. The reason is if you get too close, there will be hematoma and edema. You may not be in the canal, but the hematoma and edema will cause inflammatory reaction and compression, which can damage the nerve. So, the inferior alveolar nerve injury, when it can happen? There are 2 ways that it can happen. The first is in the initial drilling phase itself. You go too close or within the canal. Second is, you have not corrected your mistake and you place the implant also encroaching the canal. So, it can be partial implantal intrusion, full implantal intrusion, partial implantal intrusion into the mandibular canal, which can cause direct trauma due to hematoma or due to thermal damage. You are not using coolant, okay, and you are not flushing properly, then there will be thermal damage. So during drilling, these are the ways the damage can happen. And once you have done it, what you do is you place the implant also in that position. So this is going to compress the nerve. There will be hematoma, edema, ischemia, necrosis, and there will be terrible pain to the patient. And you might have to give gabapentin and other drugs also to control that. So best way is to, if you have committed such a mistake, just unwind and remove it, let it heal, plan the implant at later stage. Okay? How can we prevent it? Pre-op CT is important. CBCT is very important, particularly where you do not have an effective height for implant placement. In the initial stage itself, when you take an OPG, you will know that the canal is too close. We are not getting proper height. The canal is too close to the alveolus. So in that case, plan with the CBCT. You can choose a shorter implant height, wider implant, but blindly please do not go. So you have to take a CBCT. Then you have to keep a safety margin of 2 millimeters. Then use drill stoppers. Initially, if you are not very confident, you can use drill stoppers. Drill stoppers will be like this. It will not drill beyond that. You have set 8 mm. You have seen on the CBCT that the canal is 10 millimeters away from the crest. What you do is you have to be 2 millimeters away from the canal. So you set your stopper at 8 millimeters and then drill. Right? There is another way where you can, on the drill itself you have marking, carefully drill only that much till the depth you have calculated. Another way, you can use guides, digital dentistry. Blindly, just study the CBCT, give your data, this file, STL files are available and your DICOM files are available. You send it for a 3D printed guide. They will calculate everything, fabricate a guide. This guide will rest on the teeth, okay? And sometimes it is screwed onto the bone. And this is the position which it is, this position is decided and calculated on the computer, avoiding all the important anatomical landmarks. Okay? That is the best precise position which is there. So your work is reduced a lot, simplified. Digital dentistry is simplified. So these are the ways you can prevent extension into the canal. One more important structure is your lingual aspect. So this lingual aspect, when you are placing your incision and when you are reflecting, you have to be very careful because you have these two vessels, right and left side sublingual artery. They form a rich plexus here and anastomosis. That is why in mandibular fractures you see lingual hematoma. What is it called? Which sign? Coleman sign. So this area is responsible for that. Okay. So where do you see these? You can, on the CPCT, you can see like this. One radiolucent line is running. So these lingual vessels can enter into the bone also. Okay. So there are various dimensions. This is not important for you right now, but you have to know that there are lingual vessels which can perforate into your bone, and if you place your implant on this, there will be hematoma. You have to stay away from this also when you are planning your implant. So like this. So what you have done is you have injured this artery, which is a branch of the lingual artery. So there will be significant hematoma on the lingual aspect, just below the tongue. होगा क्या उससे? Lingual artery damage हो रही है, sublingual artery, accessory lingual canals आपके जो आपने encroach कर दिया है, and the muscles. If you strip too much, like the genioglossus, geniohyotitis, again there will be bleed because it is that area is richly supplied by your blood vessels. So if that area bleeds, what will happen? क्या होगा? अभी तो बताया, सबलिंगुअल हेमेटोमा. उससे क्या होगा? ऐसा दिखेगा, ठीक है, bluish discoloration you will see after implant placement. Patient will have pain, he will not be able to swallow, he will complain that he is not able to move his tongue. Then later he complains that I have difficulty in breathing. Should you get alarmed? Yes or no? If he says I am not able to eat, I am not able to breathe, I have a suffocation, some lump, I feel a lump which is not allowing me to move my tongue. Below the tongue I feel like a lump. So should you be alarmed? Yes. Sometimes life-threatening hemorrhages can happen which will push the tongue back and cause airway obstruction. So you can see the implant placed here in the lingual area. This curvature has not been respected because ये OPG देखा, यहाँ पे अच्छी height दिख रही है, सब दिख रहा है, हमने डाल दिया. But you have not taken your CBCT, you have missed this undercut and you have placed it in that area. And that small vessel has led to a life-threatening situation like this. Okay? So how are we going to prevent it? Precautions. When you're planning, you should be having your CBCT. You should avoid drilling the midline. On the CBCT, look for those accessory nutrient canals which are entering into the bone. Try to stay away from them. Plan in a different area. It is not that only central incisor ke liye central incisor pe hi lagana hai. Prosthetic plan is different from the actual plan that we have in the mouth. If I encounter a vessel in the central incisor area, I can skip it to lateral incisor. We can always plan the case avoiding the important anatomical structures. Then avoid long implants. You can use shorter implants if a vessel is encountered in the CVCT. And then careful surgical technique. When you are inflecting the flap, don't be very bold and just strip off everything. So whenever you are stripping the muscle, it again induces bleeding, it again induces the hematoma formation. Coming to the ramus area is important for us because that gives us bone. You can harvest bone from the ramus area for your implant procedures. So tomorrow and the next module we will discuss what happens when we extract a socket. When you extract a socket, the function is lost. When the function is lost, stimulation is lost. When the stimulus is lost, body thinks we need not have bone, so it starts resorbing. The maximum resorption is seen on the buccal aspect, anterior teeth. After some time, you will see the ridge is so narrow. And to place an implant, you need to augment bone. So the best way to place an implant is immediate. Immediate, as sir explained, you remove the tooth and place the implant. That way, you can prevent the collapse of the ridge. You can prevent the ridge resorption, residual ridge resorption. RRR जो पढ़ते हैं, ठीक है? So you can prevent that. So when you prevent the resorption and you load it, you are giving functional stimulus and then the bone is maintained. As long as the functional stimulus is maintained, Wolff's law, the bone will be maintained. There will be resorption, but not at that rate when there was no stimulus. So, ramus, the width is around 30.5, and you have to know the location of the mandibular canal, which is almost at the 2/3 distance. If you see the anteroposterior width, almost 2/3 distance you encounter the mandibular canal. So from where can you harvest the graft? This is the retromolar area, this is the external oblique ridge, this is the body part of the mandible, and this is the ascending ramus. From here, almost 5 centimeters of bone you can harvest. Where will you use it? For example, you are replacing the canine to canine. You can use this chunk, screw it here and place your implants. Now how you will stage it is again part of advanced. पहले बोन ग्राफ्ट लगा के छोड़ देना है, या इम्प्लांट के साथ बोन लगाना है, या सेकेंड स्टेज पे ऑगमेंट करना है. अगर पेशेंट इज नॉट रेडी फॉर ऑटोजीनस बोन इज द गोल्ड स्टैंडर्ड. दैट्स द बेस्ट बिकॉज there is no foreign body reaction, it is acceptable, and it has all the 3 properties: osteoinduction, conduction, and osteogenesis, because it has osteoblasts. Other bone substitutes are artificial substitutes, they will not have active cells. So osteogenesis is not present in any type of bone graft other than autogenous. So when you want to use the bone, chin is a good area. Again, 5 centimeters you can harvest from there. Ramus is again a very good area. Take it like this. So what we do is, we make a cut here near the external oblique ridge, and whatever width we want, 1 centimeter width for example, यहाँ पे हमें लगाना है ऊपर, that area you will cut. You need a contra-angle handpiece definitely. So you will mark like this. ठीक है? So one cut here you will make, external oblique ridge के यहाँ पे भी ऐसे कट करके आओगे. Then you will make one more vertical cut, depending on what size of graft you need. आपको 1 सेंटीमीटर की भी जरूरत पड़ सकती है, 2 की भी जरूरत पड़ सकती है, पूरा 5 की जरूरत नहीं है. And then this part, because see, this is cortical part, this is marrow. If you put a chisel here, this will separate. So you can harvest that. बाद में क्या होगा यहाँ पे? New bone will form. Definitely the cortical thickness will not be like this, but over a period of around 6 to 18 months, new bone formation will occur here, and this graft you can use for your implants. So you can see here, you have to make an incision, reflect. Usually 3rd molars are present there, so you can remove that, make a vertical cut here, one more cut here, and with a chisel mallet you can separate it and use it as a graft. So when you're planning your incision, now this was about drilling. Now when you are planning the incision, you have to be careful about the lingual nerve. Where is the lingual nerve? Lingual nerve lies anterior and medial to your inferior alveolar nerve. Okay? So when you are planning your incision, see like this. If it is a full mouth case, you have to give a crestal incision from here to here. So till the second molar area, you have to go on the crest, then you take a 30 degrees angle at the buccal. You don't go straight. Why we do not go straight? Because not all cases, but in some cases studies are there where the nerve can lie just beneath the mucosa here, and then it can take a turn like this on the lingual aspect. Lingual nerve, right? So if you go straight up till the third molar here or the retromolar area, two things can happen. Retromolar area has retromolar vessels. Again, profuse bleeding. If you go straight beyond 7, you are likely to cut the lingual nerve. If you cut the lingual nerve, anterior 2/3, taste sensation and general sensation will be gone. And that is very, very annoying for the patient. He has come to you for a prosthesis and he lands up in a permanent damage. So when you're planning the incision, you have to be very careful about this angulation. Come on the buccal side rather than going straight. Lingual side, never ever get your scalpel. If you want to reflect the tissue, carefully reflect with periosteal elevator. Then one more aspect you have to keep in mind is the submandibular fossa. In the video we have seen this is the area of the submandibular fossa. This is the mylohyoid ridge which is present in the region of first, second, third molar. Okay, on the lingual aspect. So this prominent ridge you will be able to feel with your fingers. Below that, try to feel the fossa. That houses your submandibular gland. Now in the CVCT, you have to make an assessment like this. If you take a cut section in the CVCT, you realize there is a big depression here or the undercut. Don't plan your implant. Like here, I said you have to place it in the center of the ridge. You go and you perforate. So, when you perforate, again the same problems. Lingual hematoma. Okay, because you have your mylohyoid vessels here, other than the mylohyoid nerve. So what do you have to do? Ideally, we want forces to be delivered straight 90 degrees to the ridge. That is the best possible thing. But now here we have to make a compromise. You have to angulate your drill and you have to angulate your implant such that you don't perforate this area. तो कैसे करोगे? इम्प्लांट को एक लिंगुअल इंफ्लेमेशन दोगे ऐसे, ठीक है? So what you can do? CBCT के बिना नहीं करोगे ऐसे cases को. You can use shorter implant. So I will not choose this length. I will choose this length, smaller length, 8 millimeters also. So that I do not perforate this area. Okay, and then tilt the implant accordingly. Then one more problem we face, as I said, there is resorption, residual ridge resorption. So after extraction, it will not remain the same. Best is this one, which has adequate height, adequate width. Adequate height is what? From the canal, you have almost 17 to 20 millimeters height. So you have all choices. Implants are available in different sizes. It can be 6 millimeters, 8 millimeters, 10 millimeters, 11.5, 12, 13. Okay. Beyond that, usually we do not get in the kit. You have to specially order if you want 16 and 18 mm. Usually we do not require 16 and 18 mm. Our 10 millimeters is the basic size that we need for an implant. And in posterior area, when the canal is too close, you can choose 8 millimeters. But less than that, we call it mini implants. That also those are also successful. Studies are there, but there is a different way of placing them. So when you see height here is maintained, width is reduced. There is significant reduction in width. Marrow is gone here. Here again, marrow as well as the width, both are reduced, and here completely the alveolar part is gone, only basal bone is remaining. So you have to see the cut section for these aspects also. Because the augmentation procedure will be different for different types of ridges. Again, this will be covered in the advanced implantology course. So from where you have to augment, how much augmentation has to be done, where you can use artificial substitutes, where you have to use autogenous, what are the other procedures like this kind of ridge, this kind of ridge. You can go ahead with a, if it is 5 millimeters width. For a 5 millimeters width, you have to have at least 7 millimeters width you need for an implant placement. Why? Because as Sir told, all around the implant you need bone. How much bone is required? At least 1.5 millimeters of bone should be present on buccal, on the lingual, mesial and distal. So this 1.5 mm of bone cover should be present. So if the ridge width is 7 millimeters, 1.5 buccal, 1.5 lingual. So 3 millimeters minus करो तो at least 4 का implant वहाँ लग जाएगा width. I'm talking about width. But आपके पास ridge ही 5 millimeter की है. 3 माइनस करो 2 मिलीमीटर का इम्प्लांट आता नहीं है. 3 के नीचे हम इम्प्लांट डाल ही नहीं सकते. फिर हमारे को कॉर्टिकोवेसिल होगा. 3 ऑल्सो सिर्फ लैटरल इंसाइजर के लिए आप यूज कर सकते हो, जहाँ पे लोड बिल्कुल नहीं देना है आपको. देयर आर कंडीशंस वेयर यू कैन यूज. सो टू अवॉइड बोन ग्राफ्टिंग, फॉर एग्जांपल पेशेंट सेज आई कैन नॉट पे फॉर बोन ग्राफ्ट एंड आई डू नॉट वांट टू गो फॉर एन एडिशनल सर्जरी. सो व्हाट यू विल डू, you will try to accommodate here. How you will try to accommodate? You can do a ridge split procedure. You split the ridge. We have expanders. You can expand, place the implant in that, allow it to heal for 3 to 4 months, and then you can load it. So that ways you get the width. But that is not possible here because there is the cortical plates have merged. There is no marrow. If you try to do a ridge split here, वो भी टूट के साइड में हो जाएगा. So you have to do a lateral augmentation. यहाँ साइड में आपको GVR करना पड़ेगा, चाहे आप autogenous से करो या फिर you choose according to the patient's pocket. Okay, so you have to see this aspect also. You have to know how the position of the mental nerve changes or the position of the canal changes with respect to age. Younger population we do not need to study because implants are not done for growing patients. Once the growth is complete, then only we choose to do implants. Till then we try to maintain it with RPD, partial dentures, till the growth is complete because it is going to change and the dentition itself is not developed. The child patient will shift from a deciduous dentition to mixed dentition, then permanent dentition. Once you have full set of permanent dentition, the jaw size also changes. So till the growth is complete, we will not advise implant placement. Once the growth is complete, we now know where is the canal. Canal will be, if you calculate superiorly, almost in the middle. Okay? And if you see the corresponding on the lingual aspect, it is running parallel with the mylohyoid line. So almost there your canal will be present. But when you look at the edentulous patients, so like this your mandible resorbs. These are not cases for your implant placement. You need to augment 15 millimeters से कम height हो गई है तो implant का case नहीं बनता है. More than 15, you have options, shorter implants का option. ठीक है, तो ये सारे अब आप एडवांस में पढ़ोगे ऐसे केसेस को कैसे डील करना है, ड्रॉपिंग ridges को. ठीक है. Then we come to the maxilla. Okay. This is embryology which we can skip. So initially when we see it is just like a slit. The maxillary sinus is like a slit. This pneumatizes as the child grows. Pneumatization मतलब अंदर air बढ़ता जाता है, cavity बढ़ती जाती है, and there is a time when the teeth may project into the sinus. हमारे लिए क्यों important है? This I think we can skip. You all know, right? The maxilla is a pyramidal bone with the base facing each other. It has four processes: the frontal process, zygomatic, palatal, and alveolar, and यहाँ पे orbital. ठीक है? So two halves make the maxilla. Total maxilla. So this half is also called maxilla. This half is also called maxilla. So what are the anatomical structures that we have to study? One is the nasal cavity, infraorbital foramen and infraorbital nerves and vessels, incisive foramen and incisive canal, and maxillary alveolar bone deficiency and its management. For example, there is excessive pneumatization. How you manage that? How you gain the height of implant in that area? Okay. Nasal cavity, you all know. From canine to canine, you will see the nasal cavity. And when you are planning the implant, for example, there was a trauma. Patient has fallen, he has lost the anterior teeth. Along with that, vertical height as well as the horizontal width is reduced. So there is a possibility that you can engage this nasal floor. The height will reduce. So your effective implant height will be calculated from the crest to the nasal floor in the canine to canine area. Like this. Another structure that you have to be careful is your incisive canal, which houses your incisive nerves and vessels. It is like this. It is straight like here. On the palatal aspect, it is going to supply the anterior part of the palate. Superiorly, if you see, it bifurcates into two. And in the middle, you have the anterior nasal spine. Okay. So, you have to avoid this when you are placing the implant. Again, problem is paresthesia and hematoma. But it is not a very big problem. Sometimes we purposefully encroach when we are not getting proper width. We purposefully encroach the canal. Sometimes we graft that area to keep the nerves and vessels away. Then is your infraorbital foramen. Again, planning your incision, you have to be very careful. Incision while doing your lateral window, dorsal nasal, and infraorbital nerves and vessels. So, hematoma. So the area that it supplies, you all know. Surgical importance. So during vein flap reflection, it can be damaged. So you have to manage the tissues gently, and you have to retract. Use the tissue retractors so that you can visualize. Posterior maxilla, these are the anatomical structures that you have to be careful about. Your greater palatine foramen, lesser palatine foramen, greater palatine artery, greater palatine which is transmitted in the greater palatine foramen, fat pad, and if there is ridge resorption or inadequate bone in the posterior area. Location, you all know, it is usually located near the distal root of the second molar and the third molar at the junction of the hard and soft palate. ये important क्यों है? क्योंकि जब हमारा connective tissue deficiency होती है, gingiva की deficiency होती है, अब हमने bone तो पढ़ लिया है. Perio is also very important for implants. Bone भी cover होना चाहिए 1.5 millimeters all around, and tissue भी width of keratinized gingiva and thickness of keratinized gingiva is very important. Otherwise peri-implantitis हो जाता है. अगर नहीं है तो you have to build. वो connective tissue हम कहाँ से harvest करते हैं? Palate से. So when you are harvesting from the palate, वहाँ पे you are likely to damage these vessels. So you have to know where the location of these vessels are. Okay. Then you have to see this height, vault, palatal vault. If it is a high arch, the greater palatine artery will be quite away from the crest. But if it is low arch, it will be close. So again, during flaps, you have to be careful. So you have to keep at least 2 mm distance from the greater palatine foramen. Then coming to the sinus. Sinus is also known as antrum of Highmore. Your teeth, many teeth are projecting into it. So when you remove, you might develop a oroventral communication. But when it is implant dentistry, you are not bothered about that. You are bothered, what you're bothered is the height available for implant placement. Okay. Then one more thing you have to know is floor of the sinus. Floor of the sinus is lined by the sinus membrane or Schneiderian membrane. Schneiderian membrane is lined by your tall columnar cells with these goblet cells which secrete mucus. Okay. So many times you will see mucoceles in the sinus. So larger mucoceles or any pathology, polyp, whatever you detect in the CBCT, first you send to an ENT surgeon, get the pathology eradicated, otherwise you will not be able to do a sinus film. Right? So this is how it looks. If you open a window, and this is how the sinus lining looks. Sinus is not just a single cavity. It may have horizontal and vertical septae. So this also you have to take into account. For example, you want to place an implant here. You can use this vertical pillar, this septa, for extra anchorage. Right? So you have to know that septations also occur. Then there is something called ostium, drainage. If the patient has thick epithelium, which is obstructing the drainage of the sinus, ostium, as you know, it is in the middle meatus. The osteomeatal complex patency is also important. You place your implant, patient's maxillary sinusitis will be aggravated. So you have to take a clearance from ENT if you detect a thick lining and obstruction of the osteomeatal complex. So this is a table which shows how far the teeth are projecting into the sinus. So according to this, the molar, first molar, palatal root and mucobuccal root of the maxillary, second molar, they are in close contact with the floor. Then you have to be careful about the posterior superior alveolar artery. You can, during injection itself, you can cause hematoma, or while reflecting the flap, you can cause hematoma. Okay. Sensory innervation, as you know, maxilla is supplied by your teeth, supplied by the PSA, MSA, and ASA. Sinuses, again, posterior superior PSA, artery and nerve, corresponding nerve. So what will you do if you have inadequate bony structure? You can raise this membrane. Inadequate means less than 5 millimeters. If you have, you need at least 10 millimeters of this distance in the maxilla, so that you can place at least 8 mm of implant and you are 2 mm away from the sinus lining. Okay. So again, from each anatomical structure you have to maintain a distance of 2 millimeters. And if you do not have this 10 millimeters height, you elevate the sinus. There are various ways of elevating the sinus. Either you can go through the socket itself, which is called indirect, or you can raise a flap and like this. So here height is not that much compromised. Through the socket itself you have a kit. You can just lift the membrane and through the socket itself you can pack bone grafts and then place your implant. So if you need 2 to 4 mm extra height, you can do like this. This is indirect technique. But if it is less than 5, you have to go ahead with lateral window technique. Lateral window is you have to give a crestal incision, raise the flap in the posterior area. I am talking about first, second, third molar area and premolar area. Raise the flap, open a window on the buccal aspect just above the teeth, alveolus basically, crestal margin, and open it. And then lift the sinus, pack some bone graft, fix implants, and forget till 6 months. Okay. Sometimes both horizontal and vertical bone loss is there. There you have to put bone grafts. Okay. Bone grafts, again advanced stage where you will handle the bone grafts, you will place the bone grafts, you will do surgery. Importance in oral implantology. And if you are what you are dealing with, where to limit yourself. You cannot venture into everything. A certain amount of expertise is required and you have to take that expertise. cases. You have to involve a maxillofacial surgeon in complicated cases. Simple things you can plan, you can do, but wherever a consultation is required, be it a ENT, be it medical personnel, you have to involve consultants and then go ahead with your case. After this lecture, you can proceed for lunch, but 1:45 you have to come to the simulation lab. Okay? We will be demonstrating the kit, how to connect the physio dispenser, how to set up your instruments. Okay?
एक प्रोजेक्ट 30 लेक्चर लेने जाना है, तो जहाँ ये जो है अपना हेलो तो वॉल्यूम कम कर कौन हंस रहा है लास्ट में अनीश के पीछे मैडम आप एक बार खड़े हो जाओ इतना मैंने आपको आज तक कभी हंसते हुए नहीं देखा प्लीज गेट अप रीजन बता दो कोई तो जोक होगा कोई जोक नहीं है ऐसे ही हंसते हो आप Sit. So starting with flap designs and suturing in implant dentistry. Okay. So these will be the contents. Now before I start with flap, ये देखो है वाला कॉलम में चल रहा है. Before we start, parodontal flap के बारे में आपको पता है? About that. Okay. Now, same flap needs to be implant dentistry. There will be little difference. Difference क्या होगा? Until I am going for immediate implant placement, that flap design will vary. Why? Because I will be having a ridge, isn't it? Conventional implantology की बात कर रहा हूँ तो वो एक ridge होगी. That's how our incision design will be. Nowadays, we are going for flapless approach when we are placing implant. Flapless means हम flap reflect नहीं करेंगे. Okay. But there are conditions which require reflection of flap. So we'll go through that. I have discussed almost everything in this, but I will be telling you what you need to remember. Your level, you need to remember few things and that's mandatory. Apart from that, if you can retain things, it's okay. If you don't, still it's okay. But there are few things which you need to know. If you are serious about this, go. So, a surgical flap is looking for the tissue which is attached at the base. Parodontal flap, आपको definition पता है. So, main जो objective है इसका flap का क्या है? It's similar to parodontal flap. I want to access the underlying tissue. तो underlying tissues में जब हम parodontal flap की बात करते हैं, मैं क्यों parodontal flap बार-बार बता रहा हूँ आपको? क्योंकि आपको वो भी याद रखना है, ये भी याद रखना है. Educates visibility. So I need to see and access the area. जब मैं parodontal flap की बात कर रहा हूँ, hello. So when I am talking about parodontal flap, I want to access the root and bone. The root surface debridement has to be done. When I am talking about flap design in implantology, my main aim is कहाँ जा रहा है implant? Bone. So my main aim is to access that bone. Clear है? थोड़ा सा difference पता चला कि what's the main objective of this flap? Okay, so this flap design is mainly to have adequate visibility and access to the surgical site. Then again, we can look for certain anatomical structures, how and when, I will tell you later, and to facilitate tissue movement. Again, if I have to advance the flap, that I will be talking later, why I need to move the flap. So, armamentarium, okay, 15 and 12 you know. 15C, again similar to 15, but it is narrow in shape. And you need a periosteal elevator. So these are the basic things you need to reflect the flap. Coming to incisions. So So we can broadly divide it into horizontal and vertical incisions. So horizontal are crestal, clavicular and circular, you know, and periosteal releasing incision. Okay. So now when we are talking about modified treatment flap, there were 3 incisions after 3rd year में practice भी की है. Okay. So those were your first incision, that is internal bevel, clavicular and third incision. उससे confuse नहीं करना. Why? That is around the tooth. This is around the bone for implant placement, especially on a ridge. Okay. So crestal, clavicular and periosteal releasing incisions are the main horizontal incisions which you will use, and vertical releasing incision you all know. Okay. So now when I talk about crestal incision, it is something like this. Can you see the ridge? I am giving an incision over there. So in sometimes aesthetic area, I can give a paracrestal, palatal or lingual incision so that I have more amount of tissue on the buccal aspect. Okay. So this is your crestal incision. Coming to clavicular and circular incision. So this is something around the tooth. So clavicular क्या है? Crevice, sulcus. So around the tooth कौन सा है? Circular incision. Sulcus में दे रहे हो आप because so when I give this incision, after this I have to reflect this tissue also. So I will be giving a clavicular incision. Okay. So this is the clavicular incision around the tooth. Then you have something known as periosteal releasing incision. So after the reflection of the flap, if I need to advance it apically, coronally, laterally, okay, I have to give vertical releasing incisions also beyond mucosa section because only mucosa is mobile. Plus sometimes I have to release the periosteum to advance this flap. So that becomes periosteal releasing incision or periosteal incision. So all these are in horizontal direction. That's why they are horizontal incisions. Next comes your vertical incisions. So whenever we are giving vertical incisions, there are things you need to keep in mind. So if you are giving it around the papilla, it should be at the line angle. It can't split the papilla like this and can't be on the prominence of the root. Why? So once you close that flap, healing will be delayed. So if you are giving on the prominence, the blood supply won't reach that area, isn't it? Part pe chadna na. Same way, if I split the papilla, it will cause that triangle. Okay. And resulting in anesthetic papilla. So your incision should be on the line angle and divergent. Basically, your base should be broader. Can you see the divergence? Okay. So these are the things you have to remember. You can't split the papilla. It can't be long and narrow. Okay. So even if you see this is on line angle. This is avoiding the eminence of the root, isn't it? But then it is very narrow and long. So you have to avoid this also. So it will come something like this and this, rather than such a narrow incision. It can't be on root prominence and your base can't be smaller than your margin. Your base has to be broader. So when we are giving vertical releasing incisions, there are few areas which should be avoided. Sometimes we need to give incision in those regions, but most probably we will try to avoid these. In the palate, because you have greater palatine artery, the lingual surface of mandible, lingual nerve, canine eminence, as I told you. Canine usually is not forgiving because As such a big pulse, definitely if you give vertical releasing incision over there, there will be flap lesions, 100%. And in areas of mental phenomena. So principles, you should use sharp blades, good periosteal elevators, try that you are not tearing the flap, okay, anatomical areas where you can find a artery or a nerve should be avoided, especially while giving vertical releasing incisions and clean margins. So whenever you are giving a crystal incision, it should hit the bone. Okay. Same way, if you have clavicular incision, it should hit the bone. The moment you do that, the reflection will become easier. Otherwise, you will be tearing the margins, you will be somehow getting stuck and reflecting a partial thickness kind of flap, which is not advocated when we are going for implant surgery. So this I have already discussed that base should be broader. Okay. So now coming to classification of flap, it's similar to what has been taught to you except for the last one. So first one is based on amount of reflection of bone or how we are reflecting the flap. So it can be full thickness, that is a mucoperiosteal flap, or a partial thickness, that is a mucosal flap. Then you have non-displaced and displaced. Means I reflect the flap, I close it there, that becomes non-displaced. I reflect the flap, advance it coronally, apically or laterally, it becomes displaced. Lastly, based on management of papilla. So here the difference is, when we are talking about parodontal flap, we have either you split the papilla or you have papilla preservation. Now over there you have a ridge, you don't have a papilla, okay. But still you can modify your incision to preserve the mesial side of the papilla of adjacent teeth, distal or double papilla preservation. How I will show you in picture. So this is the difference in the classification what we have taught you for parodontal flaps. Now how to choose the flap. Okay. So I should be knowing which flap to be used where. So based on these factors, I will be discussing various flap design and then we'll decide okay which one to use where. So few things which we need to understand is there are two main components over there. One is your soft tissue, other is your bone. So if I have good amount of keratinized tissue, there is no problem, I can reflect anyway. But if I need to preserve tissue on buccal aspect, then we have to modify the design. Same way, if I need to cover the bone defect, I need a wider flap. If my bone is sufficient enough for implant placement, then even a small reflection will suffice. So coming to what I've told you, so full thickness includes periosteum, connective tissue and epithelial tissue. So once you reflect, complete epithelium, connective tissue and your periosteum is reflected. In partial thickness, you will leave periosteum and some amount of connective tissue onto the bone. So this is the clinical picture. Can you see the bone and can you see some amount of soft tissue covering the bone? So that is your periosteum and your connective tissue. So this is the case where augmentation was done. So if you can see around the implant, you have a circumferential defect, grafting was done, membrane was placed and then suturing was done. So in such case, I need to reflect a full thickness flap, isn't it? Now, when to do stage 1 surgery? Stage 1, stage 2, you have understood? Stage 1, stage 2 is when we are exposing the implant and doing a placing the gingival cover, which will form the gingiva around the implant. So in stage 1, we don't need this kind of flap. That will be a full thickness. In stage 2, I can play around with tissues. I told you before only, I need to see the soft tissue and bone. So now I am doing stage 2, I feel my buccal keratinized tissue is less. partial thickness flap and adapted it. So now this connective tissue is remaining, plus this partial thickness on the buccal side will enhance the connective tissue on the buccal surface. So in such cases, when I don't need exposure of bone, I just want to augment the area with soft tissue. We prefer with how I will show you. So now implants are placed in this region. Incisions given, exposed. Now over here we have placed this keratinized tissue apically, isn't it? And this is the partial thickness. You can see the bone, right? So this is an example of both your split thickness as well as displaced flap. So this keratinized tissue, which will stay here, comes over here. This will get converted into keratinized tissue, and this will also get converted into attached gingiva keratinized tissue. So now you have increased the level of keratinized tissue, which was bare minimum previously. So since I don't have to do anything on the bone, so such a flap can be elevated, and I have displaced it also. Okay. So this is an example of both displaced and partial thickness flap. So non-displaced and displaced, you already know if we are placing flap at the same place or we are displacing. Initial slide I will show a incision like this. Now over here I will just reflect like this. I will leave this area to heal. Or this is distal papilla preservation, or this is something like double papilla preservation. So this is different from what you have read in. So in canonical flap, the papilla preservation was that you will reflect whole of the papilla on the buccal or parietal side. Over here, it's not like this because it's a ridge. So don't get confused. Don't draw this diagram in your flap surgery thing. Okay? And then you'll say. So now over here you can see. So this is during the stage 2. So this tissue was preserved. Can you see? This mesial and distal papilla has the reflection. The double fiber was placed. Now this tissue will come on the buccal surface. So can you see enhanced papilla as well as buccal tissue? Can you see the mesogingival junction over here? And can you see the bulb over here? Okay, so this is how you can play with your flap design based on the requirement. And requirements can be two, either soft tissue or hard tissue or both. Based on that, you have to play with this. So now coming to main flap designs. Okay, so these were the incisions, classifications. Okay, but main flap designs. So first is envelope flap. Then you have triangular and trapezoidal. Envelope is envelope with the net. So you have ना envelope. So that is envelope flap. Triangular flap will have, apart from this, one vertical releasing incision, and trapezoidal will have two vertical releasing. So whenever you will be doing initially your implantology, you will be doing angular flaps only, because other two flaps are mainly done when we want to do some amount of regenerative therapy or we need to access maybe sinus during that sinus during that time will reflect such a big flap. Otherwise, so initial implant surgeries will be done using your angular flap. So in angular flap, you will get just crustal incision, clavicular incision and reflective flap. Simple. Okay, so you have to remember two kinds of incision, crestal and your circular incisions. So this is the case. Okay, so you can see a crestal incision, clavicular, reflection of flap, implant placed. Okay, you don't need a very wide. This is another departmental case, reflection of flap using crestal and clavicular incision. So this is the crestal incision. These are the clavicular incisions and reflection of flap. So when you reflect the flap, full thickness flap, you can see the bone. Okay. Another case, where implant is placed. Okay. So these. Now, when we talk about the triangular flap, the difference is one vertical releasing incision. Okay. Usually on the mesial side, because that only will give us access to the area. So this is the case. Okay. So implant is placed, but I have a good amount of effect, isn't it? So only apical stability and 3-wall stability was achieved. This buccal wall is lacking bone. So we need to do guided bone regeneration. That will be taught to you in perio also. So guided bone regeneration is we are just aiming to gain the bone over there. So grafting and we are converting on this is titanium mesh, which was secured using tacks and screws, and this is suture. So over here, since we needed more amount of access, we have given one vertical releasing incision. So advantages are more amount of access, and we can definitely go ahead with our regenerative therapy. Disadvantages, limited access. So it has more access than your annular flap, but less access than your trapezoidal. Okay, so don't tell me आप कह रहे हो कि access बढ़ जाएगा. So limited access compared to your trapezoidal, and definitely tension on the flap will increase. Lastly, you have your trapezoidal flap. So clavicular incisions over here you can see, but we will be giving crestal when we will be doing an implant. And apart from that, you have your two vertical releasing incisions. So again, very good accessibility, but problem with this is that you have to think in mind your own vertical releasing incisions. Why? You can't modify the flap afterwards. Because now I have two dimensions. Now I can't go distally, now neither mesially, because I have given vertical releasing incision. So I can't modify this flap. Angular flap can be modified, I can give vertical releasing incision. Triangular flap can be converted to trapezoidal, but once trapezoidal is done, you stop there and then. After that you can't make changes in your flap design. Okay, so this is an example of immediate implant placement. So trapezoidal flap, after implant placement, grafting, membrane stabilization using tags. So all these are departmental cases. So based on what kind of surgery we are doing, what are the requirements, we will reflect our flap. So few modifications can be, as I told you before, in aesthetic area, it can be a paramedian incision so that I have my incision line on the palatal area rather than mid-buccal area, and more amount of tissue on the buccal side. Also during, if I am expecting grafting on the buccal side, my incision line is away from that grafted area. So chances of infection is also less. Okay. So this is a paramedian incision, it is not on the center. Okay. Reflection of a trapezoidal flap and grafting and suture. In mandibular distal extension, okay, you might be knowing about distal extension, same way, you might have to place so many implants. So either you can just give a crestal long incision and just one regular incision on the premolar, or you can these incisions, small buccal and lingual vertical releasing incision, but lingual is not preferred. I told you before. Now, these were the flap designs, which amongst these you will be using your annular flap most often. But there are certain surgical cases where you need extensive reflection of flap, like all on 4 and all on 6 cases that will be dealt in your modules when you join your course in implantology. So over there we need so much of reflection. Why? Because we need a same platform. So I need to remove the move in such cases. So that's why we need good amount of reflection. Again, since we have, when we place all on 4 like this, so to which implants go straight to go in axial direction. So we have to prevent mental foramen. So you will expose in your flap design mental nerve coming out so that you don't damage that. Okay. So complications can be tearing of flap, poor visibility if your design is not proper, and flap dehiscence if you don't follow the principles which have been told you. Now, this was about the flap designs, but nowadays we are going for flapless surgery also. See, if I have sufficient amount of correctness tissue, if I have good amount of bone, I can go for flap surgery. And if we are using surgical guides, it can be easily done. So in flapless, so you can see good amount of correctness tissue, so you remove this. We take a tissue punch, remove 4 mm of tissue from here and then place the implant instead of reflecting the flap. Okay. So definitely lots of advantages are there. Disadvantages that if I need to access the bone, I can't do that. Then again, if correctness tissue is sufficient enough, then only I can remove 4 mm of bone, soft tissue. Otherwise, regenerating 4 mm of soft tissue will take many surgeries. Okay, so we need to think about that. So this is how your flapless approach will look. Okay, so just two small punch, remove the tissue, place the implants, and done. Or you can use surgical guide. Okay. So directly you will remove the tissue, place implants, and you are done. But there is a learning curve in this. Okay, so it looks easy with guide. Again, it can be easy, but if you are doing guideless and flapless, then it requires some amount of expertise. Okay. So this was about the flap design. Any doubt? So you should remember about the incisions. What are the horizontal? What are the vertical incisions? Where you need to avoid the vertical releasing incisions. Classification of flap. Everything is similar except for papilla preservation and types of flap. So angular, triangular, and trapezoidal. So without any vertical releasing incision is your angular. One vertical releasing incision, triangular, two vertical releasing incision. And lastly, flapless, if you have sufficient amount of bone and good amount of keratinized tissue, and you are going, if you are experienced operator or you are going for a guided therapy, it can be done. Clear? So, principles of suturing. So actually this exercise you all have done in third year. The principles you must be knowing. Read out. Okay, so whenever you are holding your needle, it should be 3/4 from the tip, or from eye it should be 1/4. Okay. So again you have to enter perpendicularly, follow the curvature of the needle. Okay. From thin to thick, from deeper to superficial. Okay. And your knot shouldn't be on the incision line. So these are the few basic things you need to know. Hello. So now coming to needle. So there is point, this is the body and this is the eye. So eye is, so you have done suturing, okay, but there are swatch needles and eye test also. Okay, so You would have seen PGs doing perioplastic surgery and the needle is very fine. The thread is within the needle. So that is atraumatic or swage needle or eyeless needle. जो regularly आपने जो practice की होगी, that time you would have got a needle जिसमें एक thread पे knot लगी होगी, वो eye थी. So that becomes kind of traumatic in nature. So it can be eye or it can be eyeless. So if it is eyeless, it is also known as swage or atraumatic. If it has an eye, it definitely causes trauma because you give such a big knot. Another thing, so it can be a pointed tip with round body. It can be conventional cutting or reverse cutting. Conventional cutting is something like this, a triangle. Reverse cutting is an inverted triangle. So we would have discussed it that when you are doing suturing in papilla, if you use a conventional cutting, the moment you tie a knot, there are chances that this thread will tear the papilla. So we prefer reverse cutting needles, especially when we are dealing with papilla. Okay. So classification based on material, natural, synthetic. Example of natural, say synthetic, monofilament, multifilament. Okay. Opposite कर दो example. Absorbable, non-absorbable. Absorbable का example क्या है? You must be knowing. Again, so basically, what's the advantage of monofilament? The wicking effect is less, so chances of infection are less. But then most of these sutures, they have memory. Memory in the sense, they will come back to their original position. So you need to give more amount of throws to secure the knot. Otherwise, in multifilament, though the wicking effect is more amount of chances of infection are there, but then you have better handling and better knot strength. Okay. Example you have rated cell. So now coming to suturing techniques. So you have interrupted and continuous. So you will be practicing with interrupted only. But name classification I needed to tell you. So interrupted are figure of 8 you have done. Direct or loop suture you have done. You have done sling suture. Okay. Over here we will be talking about the matrix suture. So that's the difference. In continuous, you can have continuous sling or continuous matrix. Continuous is only one knot is there in the end. Okay. We won't be taught about this. We will be talking about only interrupted ones which you will be using. So direct loop. This is the buccal papilla. This is the lingual divide from outer surface of buccal papilla and inner surface of lingual papilla come out, tie a knot, this becomes a loop and thing, it is direct. You will practice this. Okay. In figure of 8, you will guide through outer surface of buccal, go like this, outer surface of lingual, inner surface thing. Inner surface से direct loop हो जाएगा, outer surface से figure of 8. So can you see? It forms a figure of 8. So this has been done by you people in third year as a preclinical exercise. I hope you will. Okay. So direct loop and figure of 8 you have done. Sling is around the loop, but it is for coronally advanced lab which we use. So that is not part of this presentation. So again same. Okay. So this is the figure of 8 suture. So coming to matrix suture. So it can be vertical matrix and horizontal matrix suture. I will be showing you picture then you will understand. So again, when we are talking about vertical matrix, it can be internal vertical matrix, it can be external vertical matrix. So इसमें मैंने internal की डाली है, horizontal में मैंने external की डाली. ठीक है? I will make you understand how. So around 7 mm beneath the papilla, you will go like this, exit, then 2 to 3 mm beneath the papilla and come out like this. Okay. So, अभी तक क्या था? अगर आप ये भूल जाओ, you are going like this, giving direct loop. Over here, you have two sutures coming like this, so it becomes a matrix suture. So it is in vertical direction, so that's why it is known as vertical matrix. It is going into the tissues, so it is internal vertical matrix. Okay, clear है? अभी मैं आपको horizontal दिखाता हूँ. अभी हमने ये vertical में क्या किया था? This was the buccal papilla. It went like this, lingually came back like this. Okay. Horizontal में it will go like this, come out like this. Okay. अब internal और external में क्या difference है? This is the difference. So I took a bite from here. I came from here. This is 2. Now I am going over the tissue. I am not going in the tissue. Can you see? In that I was going in the tissue. Then I will bite like this and come. And it is a horizontal matrix. If these 2 points were like this and this, the vertical हो जाता. It is like this. It is horizontal. These threads, if they were inside the tissue, it would have become internal matrix. They are over the tissue, so they become external matrix. So why these matrix switches are important? They are important because they provide a better adaptation of tissue, plus they invert the tissues. Okay. Secondly, when I give external matrix switcher, only 4-5 mm of thread on the buccal side, 4-5 mm of thread is present on the lingual side, which is coming in contact with the internal tissues. So it becomes very important using these suturing techniques when I am doing grafting in a way. Okay. So mainly we aim to do vertical or horizontal matrix suture when we are doing some amount of GBR in that region. Okay. So that minimum amount of suture material comes in contact with graft or membrane. Okay. Because if this is the implant, I have grafted this area, I am giving a matrix suture like this, it will definitely hold the flap better than your interrupted sutures. But problem with internal matrix will be so much of tissue will be in contact, so much of suture material will be in contact with your graft material. But when we get external matrix suture, the maximum amount of thread is over the tissue. Only 4-5 mm here and here, that too on the buccal and palatal surface. It is not going within the graft material or membrane. Okay. So once we will be doing preclinical again, we will show you how to go about these vertical and horizontal matrix. So remember this, like initial bite. Okay, if I rotate like this, go like this, and not, okay, it becomes external vertical matrix. This is internal vertical matrix. Like this, go like this, bite here, come out, tie out. Okay. अगर हम इंटरप्टेड डायरेक्ट रूट देखते तो वो सिर्फ यूं जाता और यूं आ जाता, ये वाली बाइट नहीं होती. So that's why it holds the papilla better and inverts the tissue. So the graft material है नीचे. Okay, so whenever we are talking about regenerative, I only told you either we'll go for papilla preservation or we'll just go for conventional flap size. While we want to preserve the tissue so that my graft material is inside. Same way, when we are suturing, we have to keep in mind that okay, we use the suture which is coming in least contact. Even when you start doing further, there will be something known as pre-suturing. Pre-suturing means I will give this suture without giving the knot, do grafting and just give the knot. So just imagine I place the graft and then I am moving like this, the graft will get in space. So there is something known as pre-suturing. You will suture but won't give knot. Once we are done with the grafting, you will just give knot. Okay. So coming to types of knots, square, surgeons and granny. You know about these knots? What about the कौन बताएगा? Square knot? when we are talking about square, one clockwise, one anti-clockwise. Okay, but मैं बता देता हूँ मेरा lecture है. So we can give a third clockwise also to secure this knot. But initially when we talk about square, one clockwise, one anti-clockwise. When we talk about surgeons, it is similar, but we give two throws. Okay. So two throws, clockwise, anti-clockwise, and a securing knot in clockwise can be given. In grannies, you have two in clockwise direction. Again, if I want to square that, we can secure it by giving one anti-clockwise. Because surgeon's knot is the one which is preferred. Okay. So conclusion is okay, you all know. So basically, conclusion is that though we are moving towards the flapless surgery, so very soon we will be starting with guide printing in our college itself. We will be moving towards the guided surgery. Okay, but then still, if I need to augment the bone, there is no other option, but I have to reflect the flap. If I am planning to augment the soft tissue, again there is no other option, I have to reflect the flap. Okay, because in guideless, definitely flapless can be done based on if you have good amount of bone and good amount of characteristics. Okay, any doubt? Sure. सब समझ में आ गया, कुछ भी नहीं आया, सब आ गया.